Good evening, everybody. I am Dr. Nirmal Prasad Neupane, a radiologist from Nepal. I currently work at the largest cardiac care center in our country, that is Shahid Gangalal National Heart Center, and I lead the department. In the next few minutes, I will be discussing with you all the role of cardiac MRI in the evaluation of the post-operative tetralogy of Fallot patients. So we'll start with the pathophysiology of the tetralogy of Fallot. And when we talk about the pathophysiology of the tetralogy of Fallot, we know that when a child is born, the two vessels, the great vessels, that is the aorta and the pulmonary artery, they are almost of equal size because of the aortopulmonary septum being medially in between the truncus. However, in case of tetralogy of Fallot, there is skewing of the aortopulmonary septum, as a result of which the aorta becomes a bit larger, but because the aortopulmonary septum is skewed towards the pulmonary artery, the pulmonary artery becomes narrower, leading to stenosis of the pulmonary artery, so that there is overriding of aorta and there is stenosis of the pulmonary artery. Because of the skewing of the of the aortopulmonary septum, there is creation of subaortic VST. And as these different factors come into interplay, there is right ventricular overload, and it leads to the hypertrophy of the right ventricle. So it comprises of the all the four components of the tetralogy of Fallot, that is overriding of aorta, pulmonary stenosis, subaortic VST, and the right ventricular hypertrophy. As we all know, the tetralogy of Fallot is the most common congenital heart disease, and it is the most common cyanotic disease with pulmonary undercirculation, and it comprises about 6 to 10% of total congenital heart diseases. So then, how do we repair the tetralogy of Fallot? So the repair of tetralogy of Fallot, it can either occur in stepwise process, or it can occur as a direct intracardiac repair. So the deciding factor being the pulmonary circulation. So if the pulmonary circulation is adequate, we go directly for intracardiac repair. However, if the pulmonary circulation is not adequate, then in those cases we try to uh, make the pulmonary circulation better uh, by different means, in the form of like creating a shunt from the arterial system to the pulmonary artery, like modified BT shunt, Lalak-Tossic shunt, etc. And when the pulmonary circulation becomes good, then only we go for intracardiac repair. So if the pulmonary circulation is good, we can directly go for intracardiac repair. And we evaluate the pulmonary circulation with the help of different ratios like Moon's ratio, McGoon's ratio, and Nakata's index. And however, if the pulmonary circulation is not good, then we go for staged procedures. So when you do intracardiac repair, what we do is, since we know that the pulmonary artery is stenosed, we break down the muscular obstruction, and we do infundibular patch or transannular patch to widen the pulmonary artery. And we do intracardiac patch repair of the VST. So since in this process, when we repair the pulmonary artery, the pulmonary valves get uh, damaged in one way or the other. So as the child grows up, then ultimately the child will start developing the pulmonary regurgitation. So as this vessel also grows with the growth of the child, pulmonary regurgitation starts to occur. And the degree of pulmonary regurgitation, its severity, will decide, along with the right ventricular function, will decide when to go for uh, pulmonary valve replacement. And for this evaluation, we will need cardiac MRI. So as I said, cardiac MRI is a non-invasive modality. The most important thing being no ionizing radiation is involved. And we can, as a result of this, we can repeat it time and again when required. And it has got, it is an accurate technique for quantifying ventricular size, function, and the valvular regurgitation. So it is considered an ideal modality in the evaluation of post-operative tetralogy of Fallot patients. However, since these patients can be quite young and might not be able to follow the instructions clearly, so we might have to use some non-breath hold techniques for the evaluation of these patients. And what we commonly do is we take stack sequences. We take total stack of the heart, and from the arch, from above the arch to the base of the heart, little below, and we take stack sequences, cine images in sequential steps, stacks, and we take them in at least two planes. So one is the axial plane and the other is the sagittal or the coronal plane. So when you take stack sequences in these two planes, then we will be able to make out all the vessels and the functions of the heart, etc. So there is no there is no definite criteria which would say that, okay, this is the point, now we have to go for PVR. So a lot of criteria have been proposed, but not so widely or globally followed. So it depends upon the severity of the pulmonary regurgitation, the ventricular dilatation, the ventricular function, and the fibrosis developing in the ventricular wall, with which we will decide whether to go for pulmonary valve replacement or not. So the proposed protocol is quite similar to other cardiac MR imaging. Like we take the survey scan of the whole thorax, that is the localizer image of the thorax, so that we localize the heart. And we do the SWiM, and then we go for black blood imaging of the whole thorax, so that we are able to look at the pulmonary vasculature. If there is conduit, then it will have to decrease the artifact associated with the conduit. We can look at the tracheal wall, we can look at pericardium, etc. in the black blood sequences. And in the dynamic, that is the bright blood sequence, which is the gradient echo sequence, we will take these sequences in different views, like in the two-chamber short axis view, vertical long axis view, four-chamber view, left ventricular outflow tract view. We'll also take right ventricular outflow tract, right ventricular inlet outlet views in these patients, so as to evaluate the pulmonary valve and the regurgitation associated with it. We take quantitative flow evaluation, that is phase contrast imaging of the aorta and the pulmonary artery, and the right and left main branch of the pulmonary artery. So it will give us what is the amount of forward flow, what is the net forward flow, what is the backward flow, what is the regurgitation, etc. And then we do the delayed GAD imaging. Delayed GAD imaging, it gives us an estimation of the fibrosis developing in the wall. It can be in the right ventricular wall or in the outflow tract, and even in the LV. So it will tell us what would be the prognosis of the patients. The larger the fibrotic component being considered to be the to be a greater poor prognostic factor. So we'll also look at the right ventricular outflow tract aneurysm, whether there is dyskinesis, etc., whether there are whether the conduit is stenosed again or not, whether the pulmonary artery is re-stenosed or not, whether any residual VSD is present, whether the aortic root is dilated and there is aortic regurgitation or not, and the quantification of the left ventricular volume and function. So as I've said, the advantage of CMR in TOF patients is that we are trying to evaluate the right ventricular function. We are trying to look at the dilatation of the right ventricle. We are trying to look at the right ventricular function. We are trying to be as precise as possible. We are trying to look at pulmonary regurgitation. What is the regurgitant fraction? And we are also trying to make out the amount of fibrosis in the RV wall. So these are all the informations that can be given only by CMR. However, it has certain disadvantages in the form that CMR takes a good amount of time when we compare it with cardiac CT, which can be done in quite few minutes. And also it needs a lot of operator expertise. And also CMR is not available everywhere. So these are the limitations of CMR. So this is a patient of tetralogy of Fallot. Follow-up of patient of tetralogy of Fallot. This is the right ventricular outflow tract view. This is the four-chamber view, short axis view, and this is the graph showing the pulmonary flow. So in the right ventricular outflow tract flow view, we can see that the right ventricle and the outflow tract is dilated. We can see that the right-sided chambers are dilated. We can also see in this image that the right chamber is dilated. When we take the flow in the pulmonary artery, we see that there is forward flow. However, we also see that there is significant amount of backward flow. So anything below this baseline is the backward flow. So this is the backward flow. So there is a large regurgitant component associated with the pulmonary regurgitation in this patient. So as I've said earlier, the pulmonary valve gets damaged in one way or the other. So slowly the pulmonary regurgitation starts. So it will lead to the dilatation of the right-sided cardiac chambers. So in this case, we see of tetralogy of Fallot, we can see that the right atrium is dilated, the right ventricle is dilated, the left-sided chambers are quite good. And as these chambers start dilating, the coaptation of the tricuspid valve is also hampered. So this patient, as a result of dilatation of the right-sided chamber, slowly starts developing the tricuspid regurgitation as well. So as I said, delayed GAD imaging can give us an estimation of the fibrosis. Like in this case, there is this patchy enhancement, mid-myocardial enhancement at the RV insertion site in the superior and the inferior aspect. There is also diffuse delayed GAD enhancement along the RVOT, right ventricular outflow tract, suggestive of fibrosis. However, when you look at the RV wall, it is red black. There is no myocardium, no enhancement. So this is good. In also in the left ventricular wall, we don't see much enhancement. So this is also a good thing. So when we evaluate post-operative tetralogy of Fallot patient, one thing that we need to evaluate is the residual VST. So it is not so common. However, if it is present, then we can evaluate it with phase contrast imaging. We can make out the magnitude of the shunt. What is the shunt? What is the QP/QS ratio? What is the amount of blood passing through the VST? We can make out with the help of cardiac MRI. Earlier, these things were possible only with the help of invasive catheterization. However, with the advent of cardiac MRI, it has become possibly non-invasively now. We can also evaluate the pulmonary stenosis, the residual pulmonary stenosis, if any. The pulmonary stenosis will be resolved at the time of repair. However, if any residual pulmonary stenosis is present or if the stenosis has redeveloped, then it can be evaluated with cardiac MRI. Tricuspid regurgitation, as I've said, occurs as a consequence of progressive RV dilatation, leading to subsequent annular dilatation of the tricuspid valve. So the tricuspid regurgitation, the amount can be quantified with phase contrast imaging along with the right ventricular volumetric data. So right ventricular outflow tract aneurysm is another complication associated with tetralogy of Fallot repair patients. So in this case, we can see that this is the right ventricular outflow tract. We can see there is aneurysmal dilatation of the outflow tract in this inlet outlet view. So this can occur where the repair has taken place. So these kind of aneurysmal dilatations can occur and it can be evaluated with cardiac MRI. Conduit obstruction is another complication associated with tetralogy of Fallot repair, and since the conduit will give rise to a lot of artifact and there can be turbulence, so black blood imaging can be taken into account when we have to decrease these artifacts, and it can provide better information in compared to bright blood imaging. LV function, so sometimes LV dysfunction can occur, and LV dysfunction has been found to be one poor prognostic parameter in follow-up of patients of tetralogy of Fallot. So we know cardiac MR is an excellent and it is the modality of choice for the evaluation of ventricular functions. So LV function can be precisely evaluated, and we can also make out what is the whether there is any abnormal septal motion, diastolic septal flattening, etc. And these things can lead to erroneous functional evaluation in echo. However, this will not be the case with cardiac MRI, as we take every slice from base to apex. we mark the endocardium, we mark the epicardium, and then we sum up the slices and come up with the data. The data in the form of myocardial mass, myocardial in-diastolic volume, in systolic volume, stroke volume, ejection fraction, etc. We can make out with CMR. So to conclude, CMR is an excellent imaging modality in the post-operative evaluation of congenital heart diseases, especially in follow-up of patients of tetralogy of Fallot. It can provide accurate information regarding the right ventricular size, volume, ejection fraction, and pulmonary regurgitation, etc. It can provide information regarding the fibrosis in the form of delayed GAD enhancement. It can provide information about the complications associated with tetralogy of Fallot, it can give us information about the pulmonary restenosis, residual VSDs, ventricular outflow tract aneurysms, etc. So cardiac MR, I would say we have found it to be a very useful and very reliable tool in the evaluation of post-operative follow-up of tetralogy of Fallot. I hope you guys find it useful, and if any queries and suggestions are there, I would welcome them. Thank you.